Okay, I'm going to go ahead and get started. Welcome, everyone. I'm Dr. Pam Cascione. I'm a professor of geropsychiatric nursing at the School of Nursing and the co-lead of the Aging Core of Penn AI Tech. And I want to welcome you to our Penn AI Tech webinar series. Penn AI Tech is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging. It's an initiative of the University of Pennsylvania funded by the National Institute on Aging. Penn AI Tech promotes the design of innovative technology and artificial intelligence methods and software to support older adults with those with Alzheimer's disease and related dementias within their home environment. And today we are very blessed to have Dr. Jessica Ancker here today, who will speak on benefits of telehealth for older adults during the COVID pandemic, findings from a Medicare study, and next steps. Dr. Ancker is a professor in the Departments of Biomedical Informatics and Health Policy at Vanderbilt University Medical Center. Her research focuses on the use of information technology to support optimal medical decision-making, and she has done work on health numeracy and literacy, health equity, and the use of telehealth, and the optimal design of electronic medical records. Dr. Ancker's research has been funded by the NIH, the NSF, PCORI, and AHRQ. I want to remind you that the talk is being recorded, and you may use the question and answer area to post questions throughout the talk, but we will wait till the end to go through the question and answers. So take it away, Dr. Ancker.
Thanks, and thanks so much for inviting me to speak to you. I'm really excited to meet everyone and to talk about some work that I'm now going to share. Here we go. Great. So this is work on telehealth that we conducted during the COVID pandemic. I'm speaking to you from Vanderbilt, but I actually started this work when I was in New York City at Cornell, Weill Cornell Medical College. And I realized that this is a group that's very interested in AI and advanced technologies, and I almost feel like telehealth is now like a simple technology. But it did turn out to be incredibly helpful during the pandemic. And I think there are some useful findings that we can be thinking about applications to other technologies as well. So I thought I would start just by casting our minds back to the beginning of the pandemic. Just, to recollect that this was not that long ago. On January 23rd of 2020, the wet markets in China were closed due to suspicion that that's where this had come from. The CDC didn't actually even start calling it COVID until February 2020. They were using all sorts of different sort of Wuhan virus type language before that point. The World Health Organization declared a pandemic in March 2020, followed very rapidly by the White House declaring a state of emergency for the United States. And particularly relevant to this project, Medicare very quickly relaxed a number of its requirements to encourage and reimburse for telehealth, given the fact that a lot of doctors' offices were closing due to fears of infection. By April 2020, we were learning what an exponential curve looked like. By very rapidly, we were seeing, just incredible impact of this pandemic, starting, I think, on the East and West coasts and then spreading really everywhere else. In the midst of all of this, PCORI, the Patient-Centered Outcomes Research Institute, responded very rapidly with this targeted call for proposals on COVID-19. And I just thought I would share a little bit of the pain. They made the announcement or they opened the system on May 5th, and then the application deadline was May 6th. So we wrote this grant in 3 weeks. So any weaknesses in study design and concept are completely due to the fact that we scrambled this together. But what we proposed to them and what they got interested in was to take a look at this very rapid adoption of telehealth that was happening within weeks and months of, at the beginning of 2020. We put together a collaboration facilitated by PCORI. That's the set of research networks that are funded by PCORI. And we put together collaborations so that we could bring together some different regions of the country to look at the impact of telehealth. And so we started this, this was all in a blur. We started this project in 2020 to start to look at the impact of telehealth versus in-person care for patients with chronic conditions, and particularly for older patients. So our project was a multi-method project. We initially started with a descriptive project. What are the features of these primary care telemedicine programs that are being rolled out so rapidly? And then the second aim is a comparative effectiveness study of telemedicine versus in-person care. However, we were very concerned about disparities in access. So we were interested in the differences that were being experienced by different sorts of patients and also different sorts of providers. And also the possibility that this intervention could worsen health disparities if it is particularly beneficial for high digital literacy patients with access to broadband, then it's possible that it would overall show a beneficial effect, but leave certain groups of patients behind. So that was the scope of this project. And I'm happy to say that we are just wrapping it up now, so I can present both qualitative and quantitative findings from this. We began with a quick sort of landscape survey of leadership at primary care practices, 100 primary care practices in 3 different states, in which we were looking at their experience of this new technology, how it was fitting with their organization, and how their providers were being trained for or not being trained for the use of this new technology. We found that there was this enormous scramble to get telemedicine programs up and running. Almost none of these primary care practices had offered telehealth before the pandemic at all. And in early months, I'm sure we all remember, they were scrambling. They were trying to use FaceTime. They were trying to figure out whether they could use audio or whether they needed video. Finally, most of them did end up switching to a platform that was integrated with their EHR. Most of them were able to adopt video visits, begin integrating video visits with the patient portal, which is something that we almost take for granted today, I think. Interpreting services were a huge barrier in the early days. There were all these reports of these sort of scramble to have the provider on literally on a phone with an interpreter with the video visit going on with the patient. I mean, not sustainable. And finally, they worked out that problem. Training opportunities, a lot of more support for patients being rolled out, fewer technology-related interruptions. And at least from the leadership level, they were perceiving that this was really increasing their access, their ability to reach their own patients. Now, we know that there are disparities in people's access to broadband, so I'll take that with a bit of a grain of salt, but that's certainly what they were interpreting or inferring, I think. We then moved on from the practice leaders to the patients themselves and the providers themselves, and understanding what their experience was during this crazy transition time. We were recruiting patients and providers who were affiliated with primary care practices at these 4 medical centers. We did purposive sampling for race, ethnicity, age, and rurality. We worked with a stakeholder board to develop an interview guide that would be have good coverage and be interpretable and meaningful. We did qualitative coding, we ended up doing a relatively large sample of 65 patients and 21 providers. We reached saturation sooner than that, but we continued sampling to ensure that we were getting the diversity that we wanted. And this project, because we had so much data, we actually came up with a lot of different products out of this qualitative project that weren't the ones that we had originally proposed. So that was actually kind of fun. We ended up involving a number of trainees and students to help analyze the qualitative data and giving them ownership over different pieces of it. I'm just going to present three of them here. The first one I'm going to talk about is the patient-provider relationship. We have a lot of concerns about patient-provider relationships. I think we use telehealth in a number of different ways, and it's often to consult with a provider that we don't have a relationship with. But in primary care, they were trying to use telehealth to continue the ongoing relationships that they already had with their patients. We did encounter quite a lot of concern about communication barriers, particularly any limitations in English were really coming to the fore in that environment. People noted that it was challenging to develop rapport, particularly if they weren't particularly familiar with the patient. We did find these sort of unexpected bonuses where a provider could see into the patient's home. And so, for example, they could meet members of the family who were important. They could do medication reviews by looking at the, medication bottles. One provider found out that their patient was a hoarder, which they didn't know before they'd seen into that person's home. So a lot of additional insight really into patients that they hadn't been aware of before. But on the flip side, we did find particularly patients were a little concerned that that they may not be getting the same attention from their provider, particularly in the early months of the pandemic when providers were often trying to take these calls from home. They weren't actually in the office. And so the environment didn't reflect that kind of professional environment that patients were accustomed to. So, the cat walks across the screen. The provider might also have family members. So some patients were really concerned that they weren't getting that same kind of quality of communication that they were accustomed to. On the flip side, we did see some patients who said it's actually better because there is no one else in the room. So overall, the patient-provider relationship, we ended up with a more positive perspective, I think, than we had anticipated here. Our second point that we had been, as I mentioned, we were very concerned about potential disparities in terms of access or use of these digital technologies. And we really did find a lot of concerns about that coming from both the patients and the providers across a number of different dimensions. We found patients who were not able to have enough broadband to conduct a video visit. On the flip side, we had patients who otherwise would have had transportation barriers. This is a patient with heart failure who had swollen feet. She was not confident that she could actually even get dressed to go to an appointment. And so the telemedicine was a blessing in that case. We saw that social and community support came out among patients who were not getting the support that they need to learn this new technology. On the flip side, we did find healthcare providers who were doing a really good job of training up those patients to use this unfamiliar technology. But again, didn't always work. The kind of technological barriers that we knew existed beforehand really turned out to be huge barriers to the use of telehealth for certain people. Finally, I'll just note that they don't close medical school and nursing school just because there's a pandemic. It turns out you need to figure out how to use these technologies when you're teaching students or precepting trainees. Everybody said they had no idea what they were doing at the beginning. They had to figure it out. They figured out how to do this by trial and error. Initially, they found it very difficult to integrate students, and then they figured out ways to integrate students into these video visits. The video visits were nice in that the preceptor could mute themselves and turn off their own camera and observe, for example, a resident taking a patient history, and then debrief with the resident afterwards. And in fact, that might have been less obtrusive than if they'd been doing it in person. So that was kind of an unexpected bonus. and a strong feeling that telehealth is here to stay, and we better learn how to integrate it into our training programs from day one. So as I mentioned, we did quite a lot of other qualitative work, but what I want to turn to now is some of the quantitative work. We use the qualitative work to try to help us make sure that we were not missing features that we should be thinking about in the quantitative work. So one of these projects was about patient-reported communication and care quality. We did this qualitatively, but we thought we would try to do this quantitatively as well. So we did a survey of electronic patient portal users in New York City. And we opened this really to all primary care patients. And so we ended up with most of them at that point actually had not had a telemedicine visit yet, but 21% of them had. So we used the qualitative findings to try to formulate questions that were going to be meaningful for this patient population to see how they were perceiving communication with their providers and the quality of care. Overall, interestingly, there were no differences in patient-reported patient-reported communication quality between the telemedicine and the in-person patients, which is not something that we had anticipated. Again, we believe that this is because these were primary care patients who were very frequently connecting with their own clinicians. And in addition, particularly in New York City at that time, telehealth was being used for COVID visits themselves. And so I think the high concern about COVID, the high need for information may have influenced people to be satisfied with their care, with that communication quality. However, even though on average, the perceived quality was good, there were certain subgroups who had some concerns. And we can see here that older patients over age 65, were less likely to believe that telemedicine communication quality was high quality. I think that fits with our concerns about technology literacy among older patients, as well as things like a potential decline in hearing quality or vision. The male versus female difference, I have no explanation for, and I would welcome any suggestions for. We found that men were less satisfied with the communication quality on telemedicine than women were. Do not know how to explain that one, but it was consistent in different subgroups. And then the final finding is the non-urgent versus urgent care. As I mentioned, some people were using telemedicine for example, COVID, but also other urgent care appointments. And in general, they were less likely to be satisfied if they were trying to use telemedicine for their routine care. For example, their routine care of their chronic conditions. These are the findings about telemedicine communication quality. We found almost identical findings when we asked them what they thought of the quality of their healthcare. And so I think that basically people were interpreting these two questions pretty much the same. Okay, so with those were the only real patient-reported outcomes that we felt confident asking about. But the major focus of the comparative effectiveness study was the quantitative effectiveness assessment. For this one, we were assuming that the COVID public health emergency was interrupting patients' access to primary care and probably making it harder for continuity of care, particularly for complex patients. And we hypothesized that this public health emergency, that these disruptions to primary care were likely to lead to what we call preventable emergency department use and preventable hospital use. So these are things like ambulatory care sensitive hospitalizations, situations in which if you had gotten the type of primary care that you needed, you would not have ended up being hospitalized or going to the emergency room. So this is a measure of healthcare quality. I'm going to say it's a bit of a blunt measure. We can imagine that primary healthcare would have to get pretty bad before we would really see this impact on the preventable utilization. However, it's particularly important if we were thinking about potentially substituting telemedicine for in-person care. Because the question arises if telemedicine is inferior to in-person care, then we would expect to see this impact on preventable utilization down the line. This particular subset of the project was led by Jiani Yu and Yian Wu at Weill Cornell Medicine. So for this quantitative study, our objective was a comparative effectiveness study looking at telemedicine versus in-person primary care. Because we wanted to use healthcare claims data, we ended up limiting this to Medicare patients. And we were particularly interested in chronic conditions. The chronic conditions that we proposed to PCORI were congestive heart failure, diabetes, asthma, COPD, and hypertension. So sort of a range of severity levels of chronic conditions. We conducted a retrospective cohort study, and we used a difference in differences approach to try to look at the changes over time and the difference between those changes over time in the two groups. We ended up, this is a decision that I'll take a moment to explain here. We ended up measuring the exposure of telehealth at the practice level. In other words, we classified primary care practices as high telehealth use versus low telehealth use. This is because we were concerned that the known socioeconomic disparities at the individual level were going to create confounding in the study design. In other words, if the poorest patients were less likely to use telehealth and the poorest patients were the sickest patients, which unfortunately is very true, then it would look like in-person care was worse because those were the patients who were seeking in-person care. For all of these reasons, we ended up deciding that the confounding would be much less if we assessed telehealth adoption at the primary care practice level and grouped the primary care practices by whether they had rapidly ramped up telehealth and were offering it to a large proportion of their patients, or whether they were slower to adopt it and using it for fewer of their patients. I'll show some of we did still control for the confounders or the potential covariates at the individual level. So race, ethnicity, rurality, dual eligibility, that is older patients who are on both Medicare and Medicaid, median income, and number of chronic conditions. So this is that was a design decision that I think was the right one, but I could imagine other people making other decisions as well. Our primary outcomes for this one were avoidable emergency department encounters, using the Billings et al. Algorithm for distinguishing unavoidable from avoidable ED encounters, and preventable hospitalizations using a similar algorithm. And then we also used two measures of continuity of care. So continuity of care is, broadly speaking, are you seeing the same providers repeatedly over time? Or is your care fragmented across a number of different providers? And there are a couple of different ways of measuring that as well. So, as I mentioned, we assessed the exposure to this at the practice level. which means that we assessed each practice. We looked at their proportion of the proportion of encounters that were being offered by telehealth, and then stratified them into high and low. And I think in the snapshot, you can see that there actually were quite a few differences between these high and low telemedicine practices. We ended up with 89 practices, sort of roughly split between high telemedicine and low telemedicine. You can see that the average age was about 72, 73, not very different there. The average proportion white was not too different, actually, there. However, the high telemedicine practices were more likely to be urban. The low telemedicine practices were more likely to be exurban or rural. The proportion of chronic conditions was also higher in the low telemedicine group. Strangely, the proportion of patients with broadband access was not very different between those two groups, which I think suggests that the different practices were not making these decisions about telehealth on the basis of whether they thought the patient population had access to it or not. I think it was due to these other factors that we were looking at in some of the qualitative findings about whether they were able to ramp up quickly. And the most stark difference was the income difference. So the low telemedicine practices had much higher rates of poverty in those practices. With that, I think you can see why it was still important for us to control for these covariates, but we do believe that we blunted the effect of this by measuring exposure at the practice level. So the overall findings from that is that we did find that telehealth was similar to in-person care in terms of preventable utilization. So the two were really very similar to each other. In that sense, this was a very optimistic finding that telehealth was able to keep patients out of the emergency room, as well as the in-person practices were, and able to keep them out of the hospital. So that was a very positive finding. That in fact, telehealth did show slightly better continuity of care variables. We are interpreting that to mean that the practices that ramped up their telehealth and were able to offer it to a high proportion of their patients were able to use it to allow their patients to maintain their relationship with their ongoing providers, whether they were primary care or specialty. However, a bit of a concerning finding was that some of the disease-specific HEDIS measures were worse in the telehealth group. So specifically, control of hypertension and control of heart failure were actually slightly worse. It wasn't enormously worse, but it was slightly worse. This, I think we can interpret this to mean that we were seeing disruptions during the pandemic to all of these patients during this time, and that telehealth was able to partly fill in the gap, but not maybe to fully offset the impact of the pandemic. After the fact, we took a look at the quantitative data, and we did see that there was an increase of telemedicine visits, but not in the overall numbers of evaluation and management visits. Those are the types of primary care visits that we were interested in here. We are interpreting that to mean that these practices were successfully substituting telemedicine for existing care, for the in-person care that was being disrupted. They were not using telemedicine to add more visits for their patients. I hope that makes sense. What we believe this means is that they were not offering more care overall. They were using telehealth to substitute for the missing in-person care that was disrupted by the pandemic. This has implications actually for the overall cost of care. If telemedicine is able to deliver the same outcomes with the same intensity of care, that's actually great. If it requires more telemedicine to deliver the same level of outcome, then we've got this sort of cost-benefit analysis about whether telemedicine is the way to go or not. But we do see here that it looks like that's what's going on, that the telemedicine was being substituted for in-person care. This work is, it's actually under peer review right now. So, there's a number of other details, and it's certainly possible that during peer review, we'll continue to refine these findings. But overall, I think we ended up with an optimistic view of telehealth at scale here. As I mentioned before, we were really concerned about these disparities. So we did subgroup analyses on the basis of race, on the basis of ethnicity, on the basis of income, and on the basis of metropolitan versus rural. Overall, all of those subgroups had similar findings in terms of avoidable and preventable healthcare utilization. So that's good. No real disparities for those primary outcomes. However, the continuity of care outcome did show a bit of a difference. And it does show that the continuity of care improvement was primarily found among the more advantaged patient populations, those with higher income, those in metropolitan areas, and those who are not dually eligible. The one exception was the chronic conditions. The continuity of care was most evident among those with more chronic conditions. And that's actually, again, quite a hopeful finding, that folks who have multiple chronic conditions, who have far more complex care, who are seeing more different providers in more different specialties, were apparently able to use telehealth to bridge some of those gaps and to maintain that continuity of care despite the disruptions of the pandemic. I'll just talk quickly about limitations here. Obviously, this is a really heterogeneous group of studies. We use different methods, we use different patient samples. So we weren't able to do a single integrated study where we did qualitative work with one patient population and then quantitative work on exactly matching that to the same patient population. However, I hope that these different methods and populations do kind of triangulate. Obviously, we were examining telehealth versus low telehealth or no telehealth, but telehealth itself changed rapidly during this time, particularly in 2020 itself. So it's very possible that the quality of the telehealth that was being offered in, say, April of 2020 is not at all what the quality of telehealth is being offered just, last month when I had to have a telehealth appointment because I tested positive for COVID again. At this point, we are really seamless in the way that we offer telehealth, at least at academic medical centers. And we've got much more experience with coaching patients, with helping people use it, whereas in those early days, we just didn't have that. And so it is possible that we were able to look at this data more granularly. The early pandemic and late pandemic would have different results. And then, of course, the pandemic itself was going on during this time. And we all know that that was creating all sorts of disruptions in our ability to track emergency room use and hospitalization outcomes. So to sort of wrap up that bit, I think we can conclude a few things with confidence and a few things with less confidence. One is that there's this massive explosion and rapid evolution in telehealth that I think is going to spill over into a lot of other technologies as well. The patient and provider experiences with primary care telemedicine were really very mixed. It was hard to come down and say, it's great or it's terrible, because different groups of people had different experiences with it. And even the same person would go back and forth and have certain great aspects of it and certain terrible aspects of it. Um, for the quantitative findings, we did find that high telehealth was associated with was comparable to in-person care in terms of unnecessary emergency department and hospital visits. It was associated with better continuity of care, but there were some worse disease-specific measures that make us feel that perhaps telehealth is not fully comparable to in-person care. And then, despite these known disparities in telehealth adoption and use, we've found only relatively small disparities in outcomes, which is good. We would have been much more disappointed if we had seen really enormous differences in outcomes. And so, the fact that there are differences in outcomes means there's more work to be done, but perhaps these hurdles are not as serious as we had originally feared they would be. You know, I thought I would include this slide. I gave a similar talk to my own graduate students, and I decided that they needed to know what went wrong too. So I thought I would just include this slide for you to say that wrapping this all up, it makes it look like, oh, we did all these great projects and it was a hugely successful project. Well, you know, it was successful, but so many things went so wrong. So I thought I would just quickly tell you about a few of them. One of the problems was that the data that we had from the PCORI institutions was great for patient level analysis, but we didn't have even identified information about the providers, let alone the practices. So there is a limitation that we had to match the patients to the practices using this merger of PCORI data and Medicare data, and it is possible that we introduced some problems with that. After we got the grant, one of our collaborators got ready to send us the data and found out that they couldn't send us the data, had to go through this whole additional data approval process, which was denied. So we had written a grant saying that we were going to get data from one of our institutions, and then that institution said, oh, no, in fact, we're not going to give you any data. Fortunately, we were able to broker a compromise over time, and they gave us most of the data that they agreed to in the grant, but that was a bit of an eye opener. We had to do contracting. We had 5 different IRBs. When we tried to match our patients from the medical centers to Medicare data, we lost all these patients who we couldn't match. We had to use the virtual data center, and every time our contract lapsed, we would lose access to it. The survey recruitment email, I don't know if I should admit this, but we submitted our IRB deviation, so I think it's okay to admit it. We had a miscommunication, and we said that we wanted to recruit, we wanted the invitation to go out to 2,000 patients. And somehow the invitation went to 20,000 patients instead. And we didn't know this until we woke up the next morning and looked at the response rate. And we had already overfilled our intended, the number that we'd asked the IRB for. So we had to close the whole thing down again and work that one out. So we went back. We ended up with a larger sample size than we had anticipated, but it was through an error, not through intention. And then, you know, this has been a 4-year project. We've had a lot of turnover. People have left for graduate school, which is a great triumph. We had 2 project babies, which is great, except that it also led to, you know, 2 family leaves, which was we had to deal with. People changed institutions. I myself changed institutions, so I've been running this remotely from Vanderbilt, even though most of the work has remained at Weill Cornell and at the other institutions. I'd be very happy to talk about challenges with managing a large multi-year research project, as well as, you know, our findings. It was part of the reason that there were so many moving parts is that we had multiple centers and many people at each center, all of whom were really essential to this project. We had great folks at Weill Cornell Medicine, Mount Sinai Medical Center, University of North Carolina, and University of Florida. And then, as is common or really required with PCORI grants, we had a diverse stakeholder board that had both patients and also providers and technology leadership, so that we could get a variety of different perspectives on things like questionnaire design and the quantitative research questions that we were asking. And they were great to work with. So I'm happy to share these slides, and I've included some of the work that's already been published on this one. But I wanted to wrap up by talking about a couple of new projects that have emerged out of this work now that we're wrapping up that large PCORI project. The first of them is, I think, a really interesting development, which is that we found initially that nursing homes were a little reluctant or slow, I think, to adopt new technologies. But now telehealth use has started becoming routine in nursing homes as well, which raises a lot of questions about how it's being used there and what are the impacts there. So we have just received a new grant from the NIA in collaboration with Hee-Young Young and Gianni Yu at Weill Cornell to look at the use of telehealth in nursing homes. In particular, we are interested in how telehealth is being used for nursing home residents with ADRD, with Alzheimer's and related dementias. The reason is obviously that these patients themselves are often not engaging in these telehealth visits, but we're finding that the nursing homes are often using telehealth to connect with specialty care in a way that was previously much more challenging, would have required visits either from the nursing home resident or from the provider to the nursing home. And so it seems possible that telehealth could help bridge the disparities that we know exist about access to specialty care for nursing home residents. We've designed this study to be somewhat similar, really, to the PCORI project that I just presented, in that we're going to start with a large qualitative project just to do a descriptive assessment of what we're finding in different nursing homes. And we'll be talking both to nursing home leadership as well as to patients and families. Then we will follow that up with a Medicare study to see if we can look at the impact on specialty care among this patient population and then patient-centered outcomes. So that project is just getting off the ground. In fact, we just had our kickoff meeting this week. So very happy to start on that journey and happy to talk about what we're finding with that as that moves forward. The other project is also really exciting, and it's unique to the state of Tennessee, which is where I am right now. This is an unfunded dissertation project by Nana Ado Padi Ajarakar with having to do with the access to municipal broadband. In the state of Tennessee, like most states in the United States, broadband internet access is offered almost exclusively by private companies. So, usually your cable provider, your internet service provider. However, there's a unique natural experiment happening in Tennessee, which is that the city of Chattanooga, in sort of southeastern Tennessee, started a municipal broadband internet service provider. They already had a municipal electric company, and they ran they used those electrical connections to their entire city to offer low cost and extremely high speed broadband to the entire city. They were able to get just extremely high rates of broadband adoption because of this. They have a free program for children, for families who have children in the public schools. And they also have higher speeds. They've consistently had higher broadband speeds at lower costs than anywhere else in the state, and also than most places in the country. So we are doing a natural experiment analysis to look at the impact of this on a number of different outcomes. So we've got access to Tennessee Medicaid data, and we can look at adoption of telehealth. We can look at healthcare utilization and negative health outcomes. Interestingly, my graduate student is also interested in educational outcomes and is obtaining permissions right now to look at rates of, to use educational data from different places in the state to look at impact on absenteeism and other negative outcomes, particularly during the pandemic when schools also switched to online. So I find this an extremely exciting project, and I feel very fortunate that that Tennessee has this unusual natural experiment that I hope that we can use to inform policy elsewhere in the country. So with that, I think I'll wrap up and say thank you so much for inviting me. And I'd love to stay and answer any questions or discuss any points that people wanted to bring up about telehealth and these projects. Pam, you're still on mute.
Fantastic. I so enjoyed your presentation, and I have many questions of my own, but we have one in the chat from Dr. Henderson. Amazing talk. Might you tell us about other pragmatic research questions that developed or emerged as part of your qualitative findings?
Yes, that's a great point. The pragmatic questions, we have, one of them was about the use of interpreters with patients with limited English proficiency. It was something that a number of us were somewhat interested in beforehand, but this project really put it front and center, and that
Yeah.
the communication barriers, particularly with people with intermediate levels of comfort communicating with English, that in person it can be very different trying to have that level of communication in person versus on the screen, and the difficulties of engaging the interpreters and the accessibility of those real-time interpreters really, I think the pandemic and telehealth exposed flaws that we knew were in the system, but we really saw them coming up. So we have now, well, and then the corollary to that is that now that we have sort of seamlessly integrated telehealth into the electronic patient portal, we're basically forcing patients to get a portal account in order to use telehealth. And so you've got this whole cohort of people who might be very familiar with video calling and not be familiar with their electronic patient portal, and the language barriers with the portal that we know it's sort of auto-translated now. And so the level of integrity of the information is just very different in English and in Spanish, for example. So we have proposed a new grant project looking at the potential use of digital navigators, training. We're looking at a couple of different options. One is community health workers. One is actually here at Vanderbilt, we've got a medical Spanish undergrad class. So we're looking at, could some of those students be trained to become digital navigators? So that's an example of a sort of a pragmatic set of questions that I think we really drew our attention.
Thank you very much. I think that lends to one of my questions, which was the sensory impairment question, which you alluded to in your qualitative data, that those patients with vision and or hearing difficulties really impacted their ability to use telehealth. Can you talk a little bit more about that?
Yes. Yeah. And I think that that's another group that we're really concerned with, particularly as we all age and all start developing lots of, different sensory issues. we found that, well, so for example, the use of interpreters did include the sign language interpreters, um, and closed captioning.
Right.
So those were, and we've seen use of, um, like, people using Siri as a dictation device. So they'll be talking and then they'll be watching the closed captioning on their phone, which can be very effective. Um, but it's still a bit of a hack. It's not like seamlessly part
A
of.
workaround.
Yeah, it's a workaround. Um, and the vision impairment, I think, is also interesting because there was a really strong preference throughout for visual calls, certainly on the part of the sighted providers. Uh, and I don't know to the extent that um, folks with limited vision were able to engage in those video calls.
Yeah,
So
that's
yeah, I think that that's another pretty interesting set of concerns.
yeah, that's fascinating. Did you hear from the providers at all that after they did these video calls that it motivated them to provide or institute home care? Like I'm thinking about the hoarder in
Yes.
particular.
Yeah, that they were able to see issues with accessibility, that the patient had sort of adapted to going around obstacles, and thinking that perhaps a home care visit could help the patient accommodate a little better around some of these things.
Right. I was thinking also about medication reconciliation if they identified problems with the meds when they had the bottles in front of them. It would be a very nice tool. And I absolutely love the new study about long-term care. Being a geropsych provider in long-term care for a long time, I
Uh-huh.
see that specialty in particular for ADRD as so critical. It reminds me of the ECHO model that we've used in geropsych to provide different consultations in that setting for others. So,
Yep, that makes sense.
and thank you so much for sharing your foibles. I think that that is so critically important, particularly for students,
Yeah,
as you
I
know,
was
they,
thinking, yeah, I was thinking when I was like internally, I disclosing all of that's fine. And then I was like, oh, I should take it out before I talk to Penn. And I'm like, what? I'm gonna just leave it in.
well, having tried to negotiate data use agreements with
Oh,
for research studies, it's very challenging. And to find out that you couldn't get data doesn't necessarily surprise me.
yeah, and it turned out it was just a situation where the PI had gone through the processes as part of the application, the site PI, and then was sort of taken somewhat by surprise to learn that there was one more data process, um, and it was this approvals process where it was a different stakeholder board that had the authority to deny um, access to the data, which we didn't really know before.
Yeah, such a challenge. We have one of our AI A2 collective stakeholders who has a question. Hi, Lily Lou, love you. She is saying, I know of a questionable 2021 project out of Stanford that captured patient testimonials and created a website, Read Telemed and Patients.
Ah,
And if you would like the information, I'd be happy to write the URL when I can refind it. Thank you for
great.
a great talk.
Thank you so
So
much. Yeah, I'd love to see that. That would be very interesting.
yeah,
Yeah.
very, very helpful. She's a wealth of information, always.
um,
I don't see any other questions, but do you have any additional stories you'd like to tell or share that could
yeah,
you
I mean, I think maybe I'll
maybe?
just sort of wrap up that AI is in your title, and it's certainly, I'm in the Department of Biomedical Informatics. It's the only thing anybody's ever talking about. And we can certainly see the applications, with some of this, for example, for providing closed captioning and things like that. But I do think that we should always be keeping in mind the utility of the last technology, the previous technology. So particularly when it comes to disparities. So, if we're talking about an electronic patient portal messaging intervention with patients, we should also be thinking about an SMS messaging intervention, going parallel to capture those patients who do not, we still have almost 15% of Americans don't have a smartphone. I just want everyone to remember that part.
Right.
And those people who don't have smartphones are probably the ones who most in need of healthcare support.
Mhm.
And so remembering that as we advance one technology level, we can't discontinue the previous one until everyone's had a chance to catch up.
Yeah, I think
So
that's a great point.
yeah, so as we talk about, AI chatbots, um, going back a step to, recall that video and even phone visits can be really helpful, um, is just something that we need to keep in mind.
Absolutely. What a fantastic talk. Thank you so, so much. We really appreciate you joining us today, Dr. Anker. And
Thanks so much.
the recording will be shared on YouTube next week, so keep your eye out for it. We will return on Thursday, November 14th at noon for our next webinar, which is entitled Designing a Digital Platform for the Aging Population with Multiple Chronic Conditions by Dr. Priya Nambisan from the University of Wisconsin-Milwaukee. So again, we thank you so much, Dr. Anker. This was just a great way to spend an hour and learn so much about the multiple aspects that you gain from this PCORI project. So we thank you.
Thanks so much.